certain chronic medical conditions in both men and women increase the risk of infertility issues and risk of having an unhealthy child. Because pre-existing medical conditions have been associated with poor pregnancy outcomes, screening by a professional is needed and advised. What do we want to share? Why do medical conditions matter? What are medical conditions? And we give also an overview. The prevalence of chronic medical conditions is increasing in the general population and among men and women who are at reproductive age. Several pre-existing chronic medical conditions can cause adverse maternal and fetal pregnancy outcomes. Preconception care aims to detect and control these conditions in order to improve pregnancy-related outcomes. To guide reproductive life planning, women with chronic medical conditions need information regarding the risk of pregnancy complications and maternal morbidity and mortality, fetal well-being, and the ability to become pregnant at present time or in the future. This presentation presents an overview of pre-existing medical conditions of the respiratory, cardiovascular, neurological, gastrointestinal, and endocrine system, followed by a genetic condition, and also the immune system gets our attention. To finish the overview, we discuss cancer. We summarize the points of care that healthcare professionals should consider concerning preconception and the pre-existing medical condition. Because an optimal pregnancy timing is important for women with chronic conditions, the use of contraception is our last key point. Which conditions will be handled? We handle asthma, hypertension, thrombosis and embolism, epilepsy, migraine and tension headache, thyroid conditions, cystic fibrosis, inflammatory bowel disease, rheumatological disease, and cancer. First, we start with asthma. Physiologic pregnancy changes interact with the pathophysiology of asthma. There are positive effects, for example, bronchodilation during pregnancy, and this is due to pregnancy hormones. But also there are negative effects. Pregnancy increases the oxygen consumption with 20%. To compensate this need, minute volume will increase by 40 to 50%. As the uterus enlarges, it pushes the diaphragm up, which results in a reduction of lung capacity. In consequence, around 75% of the pregnant women with asthma suffer from dyspnea. Acute asthma exacerbation during the first trimester increases the risk of congenital malformations and must therefore be avoided. Uncontrolled asthma can cause low birth weight, preeclampsia, and preterm birth. Most asthma medications can safely be used during pregnancy. Inhaled corticosteroids are the preferred therapy. But evidence learns us that half of women stop their therapy once they are pregnant because they fear the side effects. Healthcare professionals have to inform and motivate to continue their asthma therapy. Women should be aware that poorly controlled asthma can put the fetus at greater risk than their asthma medication. Heart disease remains an important cause of death in young women. Cardiovascular problems should be considered in women who attend a preconception consultation. If present, referral to a specialist is needed and individualized and interdisciplinary guidance should be started. Thrombophilia is a condition that causes increased blood clotting and is associated with an increased risk for deep vein thrombosis, lung and brain embolisms, and arterial thromboembolic processes. Women with a history of deep vein thrombosis and superficial thrombophlebitis are at higher risk to develop thrombosis and embolisms during pregnancy. Screening for thromboembolic history is a necessary step during the first preconception consultation. If women mention problems, they should be referred to specialists. Please take in mind that oral anticoagulants with warfarin are teratogenic and have to be avoided. They can be substituted by low-weight heparins, which are less teratogenic. Seizure disorders like epilepsy are common in women of reproductive age care. 6 in 1,000 women have a form of epilepsy, and 1% of pregnancies are complicated with epilepsy. Epilepsy is associated with significant morbidity and mortality. Possible complications are miscarriage, low birth weight, and congenital fetal malformations, including cardiac malformations and neurodevelopmental problems. Please inform women that convulsions during pregnancy are more frequent. They are caused by increased sleep deprivations, changes in medications, and lapses in therapy compliance due to the fear of congenital malformations. All four groups of epilepsy treatment, phenytoin, carbamazepine, valproate, and phenobarbital, are associated with congenital malformations. Women with epilepsy or seizure disorders should be well informed during the preconception period about the aforementioned risks. A planned pregnancy is recommended under supervision of a multidisciplinary team, including a neurologist. The target during preconception is to avoid maternal seizures. The neurologist should aim for monotherapy in combination with a lower dose medication. Women on seizure medication must take folic acid supplementation up to 4 micrograms per day, starting at least 1 month before conception until the end of the first trimester. Please note that antiepileptics affect the effectivity of hormonal contraception, which makes pregnancy difficult. Headache is a frequent reason for referral to a neurologist. Mostly women are affected, and the peak incidence is situated around their 20s and 30s during the reproductive period of women. However, migraine improves during pregnancy. There seems an association between migraine and developing hypertension and preeclampsia. Evidence also shows a higher incidence of preterm delivery. It is important to note that migraine patients mostly manage the headaches themselves by over the counter medication. As health professionals, we have to advise women known with migraine and the pregnancy wish to contact their GP or neurologist what to do in case of a migraine attack. Triptans and ergotamine should be avoided because of the teratogenic effects. The manifestation of thyroid diseases varies and is related to the availability of iodine in the diet of men and women. Iodine is essential to produce thyroid hormones. In 1,000 women, 6.2 suffer from thyroid disease due to a lack of iodine in the diet or due to an autoimmune problem. Because euthyroidism is necessary for the development of a healthy embryo, health professionals should screen for 3 types of thyroid disease: hypothyroidism, subclinical hypothyroidism, and hyperthyroidism. As a result of increased estrogen levels, the need for thyroid hormones in pregnant women increases, starting at 5 weeks of gestation and stabilizes from the 16th to 20th week of pregnancy. Healthy pregnant women can meet the extra need by producing more thyroid hormone. This will not work in case of maternal hypothyroidism. Extra supportive medication as levothyroxine is needed. In un or undertreated hypothyroidism, sub or infertility is possible. There is also a much higher risk for miscarriage. Long term consequences are impaired cognitive and psychomotor development. Subclinical hypothyroidism manifests as the thyroid gland that is functioning well and is producing normal quantities of hormone but requires additional stimulation to maintain normal output. The disorder affects up to 3% of women at reproductive age. Subclinical hypothyroidism in pregnancy is also associated with an increased risk of pregnancy complications. Hormonal supplementation during pregnancy is safe and therefore recommended. Hyperthyroidism affects around 1% of the population at some stage in their lives. Women affected by this condition are at increased risk of thyrotoxicosis, especially around the birth. In addition, there is an increased risk of miscarriage, intrauterine growth retardation, and premature birth. The expecting mothers risk preeclampsia, solutio placentae, heart failure, and stroke. Due to these severe risks, individual preconception care is needed in women with hyperthyroidism for optimizing the disease and its therapy. Cystic fibrosis affects lungs, the gastrointestinal tract, liver, pancreas, and testes by producing tough mucus. Men and women have a shorter life expectancy due to the occurrence of chronic respiratory infections. However, with improved care focused on optimizing nutrition and respiratory function, most people with cystic fibrosis now live into adulthood, and rates of pregnancy have increased over time. Cystic fibrosis causes impaired fertility in men, for example, inhibition of sperm transport, and also in women with a menstrual disturbance, changes in cervical secretion. Reproductive assistance is often needed. Preconception care can help couples to conceive physiologically. The majority of pregnancy have a healthy outcome. Once pregnant, women risk respiratory failure due to the physiological deterioration in respiratory function during pregnancy. Mostly the deterioration passes. Complications such as miscarriage and preterm labor are common. The risk depends on preconception lung function. Therefore, preconception counseling needs to be individualized. Inflammatory bowel disease affects up to 1% of young women and men. Fertility can be impaired in both men and women. This can be caused by both disease activity and previous surgical intervention. Active inflammatory bowel disease at the time of conception or during pregnancy is associated with an increased risk of complications. The primary aim of the preconception care is to ensure that the maternal disease is stable. Rheumatological disease is on the rise in women of reproductive age. The morbidity and mortality rates are associated with the specific therapy that women follow. A specific preconception care plan for women suffering from rheumatological disease will depend on the type of disease and the therapy used. The last disease that we will present is cancer. The incidence of cancer slowly stabilizes with an estimated 1.7 million new cases in 2018. Advances in cancer treatments have improved the outcome for pediatric cancers, with 80% of children now surviving 5 years or more. Unfortunately, 5-year survival rates for adolescents and young adults remain lower. Compromised fertility occurs in 12% and 66% of at risk female and male survivors of childhood cancer. Standard options for fertility preservation include sperm, oocyte, and embryo banking. Diagnosed cancer patients with a pregnancy wish or a future pregnancy wish must be informed as soon as possible and fully about the influence of cancer and the treatment on fertility and the future pregnancy. Also, the possible options for fertility preservation has to be mentioned. Referral to specialists in oncofertility has to be recommended in time. Women of reproductive age with chronic conditions are at risk for unplanned pregnancy. This risk is caused by a reduced efficacy of the contraceptive medication due to their therapy. Because women with medical conditions are at higher risk of pregnancy related complications, timing for pregnancy is important. So, effective contraception is needed. The choice of contraceptive will depend on the woman and her medical history. Planning a pregnancy opens the possibility to start optimal and customized preconception care, which aims to stabilize the pre existing medical condition before pregnancy. And so we have here our concluding remarks. The medical history of couples with a pregnancy wish needs to be examined. A checklist can be used to screen for specific pathologies or medical conditions that may affect a future pregnancy or the fertility of men and women. The prevalence of couples with a pre existing medical condition that want to be pregnant is increasing. As those medical conditions can be associated with maternal and fetal complications, starting a preconception care consultation with an interdisciplinary team is indicated. However, most women with a chronic medical conditions do not think about reproductive life planning. This calls for an increased awareness among men and women. And also, the involved healthcare providers should be aware of the importance of pre pregnancy preconception counseling in couples with chronic medical conditions. Patients in their reproductive years should be routinely asked for their intentions to become pregnant. Management of chronic medical conditions needs customized care. This approach also applies to preconception care. Broad recommendations can be suitable for many women with a pre existing medical condition, but can be unsuitable for others. Therefore, person centered care is vital. If you want to know more about factors affecting fertility, please check our Preconet webpage. Thanks for your attention.